So to sort of backtrack, we were a primary T-guided appendage program as of about 8 months ago, and we've made that transition slowly over the past 8 months. And so my experience on this talk is going to be based on my experience of about 40 cases or so that we've done since this time. So, we've always talked about how TE is the gold standard and it's a safe way of imaging the left atrium. And most of this data that establishes the safety of TE dates back to the 90s, early 2000s, when majority of the TE was used as an imaging tool. These were shorter procedures, about 15 minutes on average, and not necessarily to guide structural interventions, which has been the case over the past couple decades. And therefore, in this setting, the duration of the TE has increased. And so this was a very interesting study that there was about 50 patients. You look at an EGD pre and post a structural intervention, and we found that the mean duration of the TE was about 86 minutes. And in these patients, there was 86% of the patients developed new injury, of which 40% were complex lesions. And the predictors of this were poor image quality and the length of the procedure. And with this, you might wonder that, I routinely use TE for my imaging in structural interventions, and I've not seen any clinical impact on these patients. Patients seem to do well. And that's true. These patients did not really have any significant clinical impact. There were a couple patients that needed to be monitored for a day or two after finding these complex lesions, but that was about it. But it certainly puts into question about the safety of TE, particularly for complex interventions. But on the flip side, we have familiarity with the TE. We know how to assess the appendage. We can get good quality, high fidelity images, and we can rule out with confidence that there is no clot in the appendage. And we're also comfortable with the views. We know that these are the views we're going to get and the anatomic landmarks we have. So then why the change? Well, the ICE catheter can do just as much as the TE can in assessing the left atrial appendage. So you come in from the femoral vein, you go transeptal and assess the appendage in different views within the left atrium, and we'll talk about those. But you really get good quality images with that too. You can rule out the appendage of any clot. You can see the circumflex. You can see the Coumadin ridge. You do get equally good quality imaging. So what does the data show? Well, there is no randomized clinical data comparing ICE and TE, but this is the ICE LAA study that looked at about 100 patients, and what we found is that ICE-guided TE is effective as well as safe in using ICE as the imaging modality for appendage occlusion. And while there is no RCT data, this is a post-hoc analysis comparing to Pinnacle Flex, which use TE for guidance, and you can see that the outcomes are really comparable. And this is some data from the LAO registry, the SURPASS registry, that is looking at patients getting appendage occluders in US. This is between 2020 and 2021, and you'd see that 80% of them is still guided by TE. About 6% use ICE, and there's an overlap of ICE and TE in about 14%, probably the centers that are slowly moving from TE to ICE. And what you see in the bottom is that ICE and TE are effective in closing the appendage. There is a higher risk of pericardial effusion with ICE and much lower use of general anesthesia with ICE. And I think some of this is a volume issue, right? As we learn to use ICE, I think the safety of ICE-guided TE is going to improve. The pericardial effusion rate is probably going to improve. There's going to be a further reduction in the use of general anesthesia, and this will become a conscious sedation procedure. So switching gears, let's talk about how it's done. So breaking it down, transeptal puncture and the device implantation. Now, we're all very comfortable with TE for a transeptal puncture, right? Because it is biplanar imaging. You know, you can simultaneously look at the anterior, posterior, superior, inferior. You're confident about how you can get across. But that remains true even for ICE. As you have that transeptal catheter up in the SVC and you drag it down, you will see the catheter come from the superior aspect to the inferior aspect on the fossa. And in terms of anterior and posterior stick, what you're looking at is the far field. So if you're seeing the mitral valve come in, you know you're anterior. If you're looking at the right veins, you know you're too far posterior. And what you want to look at is have the left veins in field. And that makes sense because the appendage is in close proximity to the left vein, so you know you're in the right space. And then once this is done, I have found Baylis to be almost revolutionary in the ease and efficacy and safety of these transeptal punctures. So this is a RF guided puncture, and you energize the septum once you're at the right location. You advance the pre-shaped pigtail 035 wire into the left atrium, and then you advance this 12 French sheath. I usually floss it a couple times. I floss the septostomy a couple times, and then I pull back this catheter in the right atrium. And what I do after this is slowly advance the catheter until it approximates the septostomy, and now I have a fluoroscopic landmark of where I want my ICE catheter to go. And then between the fluoroscopy and ICE imaging, you can navigate your ICE catheter from the right atrium into the left atrium. What about device implantation? So we're all familiar with TE and using TE in multiple views from 0, 45, 90, and 135 to look at the appendage overall, determine the size, and therefore the size of the device. And the ICE has different views, but gives us the same information. So the three ICE views to be familiar with is the mid-left atrium view, or the home view, the left pulmonary vein view, and the supramitral view. This is the mid-LA view, or the home view, and so you have the catheter sitting in the body of the left atrium. Sometimes you have to rightward rotate the knob a little bit, and oftentimes retroflex or go with a little bit of posterior tilt, so you're looking up at the appendage, and this would be the equivalent of a 45-degree view on TE. What about the pulmonary vein view? So from the home view, if you slowly clock the catheter, and I think slowly is really the key here. It is micro movements and finesse movements of the ICE catheter to be sure and wait for torque transmission of the ICE catheter within the left atrium, as well as close attention to the change in anatomy and anatomic structures that you're seeing on the imaging. And as you clock this catheter from the home view, you will see the pulmonary vein, the left upper pulmonary vein come in. And once you see that, and be sure that this portion, so this is the inferior part of this imaging, and this corresponds to the superior part of this imaging of the distal tip. And you want the distal tip to be in a black space, which means blood, which means it's not abutting any structures within the left atrium and is safe to advance. And once you have that in the black space, you slowly advance it in the pulmonary vein. And then you're looking down from the vein in the appendage, which is about the 90-degree view, and then you can rotate clock or counterclock and left and right to fan through the appendage. And then the next is the supramitral. So you come back to the body of the left atrium, and you have the mitral valve in view. And from there, you slowly clock until you see the structures moving, until you see the right vein come to about 6 o'clock. And after that, you do a hard posterior tilt so that the catheter sits just above the mitral valve and is looking up at the appendage. And this is the equivalent of a 135-degree view on TE. And then once you have this, usually I find that the ICE catheter remains stable in the supramitral view or the pulmonary vein view, and then you can use this to form a ball and then release the device. A quick appendageogram after that, and then using the same views that we talked about to determine whether the device implant meets pass criteria. And you can also put color, make sure there's no leaks, and then release the device. So things to keep in mind, and some of the things that I've learned over my experience of these past few months. First is pre-procedure planning. So as in anything, planning is obviously the key. And as we made this transition from TE to ICE, we really chose the right patients. We avoided patients that have had prior clot in the left atrium. We avoided patients that have had documented prior ischemic strokes. Any hostile septum, either prior septostomy or a thick limbus, we avoided those cases up front. Anesthesia has been another moving part in our lab. Obviously with TE, the patient is intubated GA and there's anesthesia support. And as we transitioned from TE to ICE guidance, we didn't completely get rid of anesthesia. So anesthesia is still in the room. We've moved from simultaneous TE and ICE to T on backup only. So patients are no longer intubated and there's no general anesthesia, but the anesthesiologist is performing the sedation as MAC, with the goal of, as we continue to gain experience, move towards nurse/conscious sedation in the lab. Clearing the left atrium of clot is another important aspect. The way we've set up the program is using CTA, done about 48 hours prior to the procedure, for a couple things. One is it has a high sensitivity to clear clot, and that way there is ways using ice to go on the right side and assess the appendage without having to do a septostomy, to go on the right side in the pulmonary artery and look at it. But there's a lot of manipulation of the catheter involving fragile structures on the right side, and I wonder if that's related to an increased diffusion. So we found that screening using CT to be a more effective and safe way of doing it. And then the other important thing is to assess the anatomy on the CT scan, and that helps us determine which are the high-risk anatomies. If it's an anterior chicken wing, it helps us determine what part of the fossa do we want to make the septostomy in. You know, in the initial stages of appendage occlusion, there was always a push to go posterior and inferior, and while that might be while that might work well for most appendages, it's not true for all. If you have an anterior chicken wing, you want to be inferior and anterior. And so using the CT to understand the anatomy and then finesse the stick on the fossa has been really helpful. And then the ICE exam, just as we talked about, take your time with the views, embrace the learning curve, and it really has been quite transformative in not just getting patients home the same day, but also patient ease and comfort, as well as us getting familiar with the ICE catheter, which is here for the future, and is sort of the same skills that you can translate to ASD, PFOs, and other structural interventions. Thank you.
Thank you very much. That was a good talk. Stay there, Vigyan. Vigyan, stay there. Any comments from the panel about intracardiac echo? I don't think intracardiac echo is, in general, very popular in India, correct? Yeah, because of the cost. Am I right about that? Yes. Because in US, we do all PFOs and ASDs by ICE, but not, yes, Dr. Verma.
ICE is available in India. 1,20,000 is the cost of the catheter.
That's the problem.
And it is used in quite a good number, not very low number, but it's not very large number either. And it is very useful, especially when you think you're taking a risk for anesthesia and doing a T. Here you may not need an anesthesia to do T.
Yeah.
So that's some of the advantages.
Yeah, so but basically I wrote the book chapter ICE in the beginning, but I'm not very convinced for left-sided structures, because the intracardiac echo probe is best visualizes the right-sided structures, like ASD, septum, tricuspid valve, pulmonic valve. So when we do pulmonic valves or tricuspids, actually I find ICE very useful. As soon as you go to left-sided structures, because the left atrium is behind the esophagus, in front of the esophagus, right behind, you get high-resolution pictures of the left-sided structures. And that's the reason why we do left-sided procedures by ICE. But the only way to get around it is you have to do a you can go dual transeptal and go through with ICE. See, if you look at the cost, you have to do a CT, right, before. That's another extra cost. Then you had the anesthesia in the room, so there's no extra benefit, right? So you didn't save any money on that. The only issue is the convenience of the non-intubation at right moment. Now, it might become better over time. And so in some patients, I agree that in those frail people, it might be good. See, for us, for my appendage occlusion program, indication of closure is a femoral vein and Medicare insurance. And then they come to the table and I do a T baseline and there's no thrombus, we just go ahead. Yeah. Now we are lucky to have cardiac anesthesia. And there's some hospitals where there's logistic issues of not getting anesthesia available. So for those cases, I think it's very reasonable. And in some cases, in absolute contraindication, it's very reasonable. But still, even in the United States, less than 10% of cases are done by ICE, even now. And then, of course, 3D ICE is going to come up, which is now better, but it's very expensive. It's $3,000.
No, absolutely. I think those are such great points. And the impetus for us to switch was what you described, is the difficulty with anesthesia. I agree. I think 3D and 4D eyes, in my opinion, the imaging quality is not there yet. It is a 12.5 French catheter as opposed to an 8 French catheter for 2D eyes.
And they're
But
crystal, and the resolution is still not the
the
best.
resolution is still not there. But I'm hopeful that over time, as the technology matures, that this field moves towards a low profile and high fidelity 3D and 4D eyes catheter with the same skills that would then translate. And we're hopeful within the next 20 cases or so that we move out the anesthesiologist within the lab, and I think we should be able to get there.
Just one basic question. When you are deciding to do LA appendage, you know that you are going to be posterior, inferior for the septal. So where exactly you want to puncture for the eyes catheter? Because you need to have 2 punctures.
Yeah, that's
so
a great.
Where you are planning to do
That's a great point. So there are 2 ways it is done. There are some people that do 2 separate punctures. In that case, the puncture for the ice, I would imagine, would be different than your primary puncture, which you'd reserve for the appendage. But that's not how we do it. We do the same side. So I use the transeptal sheet to floss the septum, then first get the ice catheter across with the wire across. Keeping that wire is really helpful in splaying that septostomy and having a fluoroscopic marker. And then we've really had no difficulty advancing the sheet parallel.
Sir, so one question.
Yes, please.
Sir, right. Sir,
Sorry,
from
yes.
the panel, sir. Okay, sir. Regarding the indications, the depth of the left atrial appendage with the width of the ostium, sir. So how would you be sizing the device? That's actually one query.
In by ice or by regular?
Yes, by ice and also by regular actually.
Regular.
I wanted both.
T.
And the T and ice.
So, see, the thing is that he does CTs before.
Yes.
Okay, so when you do a CT before, you can absolutely accurately measure the left atrial appendage and the size. So you don't need another imaging tool. So they primarily use that. See, if you're using primary ice without, I don't think they are ready yet. So we have to do a pre-procedural imaging before that, right?
Yes, absolutely.
Yeah. But I told you, in my small, poor hospital, I can't afford so many tests. So I just do femoral vein
I will-
and Medicare insurance.
I will admit that with this transition and while we're in the early phase, I miss those 30-minute appendages. It takes us longer on average.
Sir, how often do you use ice? Do you use it for every case of
We've
yours?
transitioned to complete ice.
I don't use ice. I only use it if it's an older patient and he has a problem in swallowing. That's it.
Thank you.
Our anesthesia is actually, we are very lucky. We have five anesthesiologists who do Watchman, 4 do mitrectomy, and 1 does tricuspid.
Can you share them with us?
Oh yeah, you train them first.